Hello and good morning everyone. This is Dr. Mohammed Ali and we are on the second part of video presentation on anti-epileptic drugs. In this video presentation, we will be discussing important aspects of anti-epileptic agents. So let's get right into it. Phenytoin is well absorbed generally when given orally. However, it is also available as IV form in case of emergency. It is largely protein bound, 80 to 90%. It induces liver enzymes, metabolized by the liver to inactive metabolite. Its metabolism shows saturation kinetics and hence half-life increases as the dose increases. It is excreted in urine as glucuronide conjugates. Plasma half-life is approximately 20 hours. Therapeutic plasma concentration 10 to 20 micrograms per ml. So it has a narrow margin of safety. This is the dose. Now let's talk about the mechanism of action of phenytoin. Phenytoin blocks voltage-gated sodium channels by selectively binding to the channel in the inactive state and slowing its rate of recovery. Its clinical uses includes partial seizures and generalized tonic-clonic seizures. Phenytoin is an old but effective antiarrhythmic agent for the suppression of ventricular fibrillations. Its properties are highly similar with class 1B antiarrhythmic agents like lidocaine, mexiletine, and thucyanide. Its dose-related side effects include GI upsets. Neurological effects include headache, vertigo, ataxia, diplopia, nystagmus, or sedation. These are the non-dose related side effects of phenytoin, which includes gingival hyperplasia, hyperplasia of gums, hirsutism, hypersensitivity, hepatitis, which is rare, and this is important, fetal Hayden-Toyne syndrome, which includes fetal malformations, cleft lip, cleft palate, hypoplastic phalanges, microcephaly. Bleeding disorders is usually common in infants if you are taking it in pregnancy or lactation. Osteomalacia it can also cause due to abnormalities in vitamin D metabolism. Now let's switch gears and talk about the pharmacokinetic interactions of phenytoin. It is important to recognize that if any agent inhibits liver enzymes or P450 enzyme system of the liver, then it would certainly enhances or increases the levels of other agents in the plasma, taken together or concurrently. So in case of phenytoin, it actually enhances the level of chloramphenicol, which is actually an inhibitor of 50S ribosomal subunit, protein synthesis inhibitor agent, and isoniazid, which is an anti-TB agent, by decreasing their metabolism. It also induces liver enzymes and reduces the plasma levels of other agents taken together or concurrently. For example, carbamazepine, another antiepileptic agent, and rifampicin, an anti-TB medication. Carbamazepine is also an important anti-epileptic agent. Its mechanism of action and clinical uses are similar to that of phenytoin. However, it is also commonly used for the treatment of mania and trigeminal neuralgia. Trigeminal neuralgia is a chronic medical condition associated with pain along the path of the trigeminal nerve. Now let's talk about the pharmacokinetics of carbamazepine. It is available as an oral form. It is well absorbed from the GIT. Around 80% of it is protein bound. It is a strong inducing agent of P450 enzyme system. It is metabolized by the liver. Carbamazepine is excreted in urine as glucuronide conjugate. Its plasma half-life is around 30 hours. It has a narrow therapeutic index and has a therapeutic plasma concentration of 6 to 12 micrograms per ml. Its dose is around 200-800 milligrams per day, and it is given 12 hourly as sustained release form. Carbamazepine is excreted in urine as glucuronide conjugate. Its plasma half-life is around 30 hours. It has a narrow therapeutic index and has a therapeutic plasma concentration of 6 to 12 micrograms per ml. Its dose is around 200-800 milligrams per day, and it is given 12 hourly a sustained release form. Now let's discuss some of the important side effects of carbamazepine. Hyponatremia and water intoxication are the specific side effects of carbamazepine. Other side effects include GI upset, drowsiness, ataxia, headache and diplopia, double vision. Hepatotoxicity is a rare side effect of carbamazepine. Its teratogenic effects include congenital malformations, craniofacial anomalies, and neural tube defects. It can also cause late hypersensitivity reactions. It can also cause blood dyscreasis as fetal aplastic anemia. Also, this is about the pharmacokinetic of valproic acid. It is available as capsule, syrup, IV form as well, metabolized by the liver into inactive metabolites. It has a high oral bioavailability. It inhibits metabolism of several drugs such as carbamazepine, phenytoin, topiramate, and phenobarbital. It is usually excreted in urine through glucuronide conjugation. Plasma half-life is 15. Sodium valproate or sodium valproic acid exerts its mechanism of action through multiple ways. It has the capability of blocking sodium channels. It can also block GABA transaminase enzyme, which is actually responsible for the metabolism of GABA. And it can also block low voltage activated T-type calcium channels as well. Sodium valproate, is a blocker of sodium channels and low voltage calcium T-type calcium channels as well. Clinical uses includes very effective against absence myoclonic seizures, but also effective in generalized tonic-clonic seizures, primary generalized seizures, less effective as compared to carbamazepine for partial seizures. And like carbamazepine, valproic acid also can be used for the treatment of mania. So these are the side effects of sodium valproate. The most important one is the hepatotoxicity. It causes centrilobular necrosis of the liver, hepatocytes. But the chances are very rare. It also causes thrombocytopenia and neural tube defects. This is the teratogenic side effect. For example, spina bifida, the offsprings of women, contraindicated. That's why it's contraindicated as well. Lamotrigines, pharmacological effects. Resembles phenytoin and its pharmacological effects well absorbed from GIT. Mechanism of action includes inhibits excitatory amino acid release, glutamate and aspartate by a blockade of sodium channels. It's used as add-on therapy or as monotherapy. Side effects: skin rashes, somnolence, blurred visions. So skin rash is very important as far as lamotrigine is concerned. This is the specific side effect of lamotrigine, but other effects are also important. Now, gabapentin. Gabapentin is a structural analog of GABA. It was initially designed to mimic neurotransmitter GABA. It does not, however, binds to GABA receptors. Its mechanism of action as an antiepileptic agent likely involves its inhibition of the alpha-2 delta-1 subunit, accessory subunit of the high voltage activated calcium channels. In this way, it inhibits calcium influx into the neurons and decreases glutamate release from the vesicles, hence decreases glutaminergic transmission. Its pharmacokinetics involves: it is not bound to plasma proteins, it is not metabolized by the liver, and excreted unchanged in urine. It does not induce or inhibit hepatic enzymes, and that is highly similar to lamotrigine. Its plasma half-life is around 5 to 7 hours. So patients could experience these side effects after taking gabapentin. They can be somnolent, meaning state of feeling sleepy, dizziness, vertigo, ataxia, gait disturbances, fatigue, tiredness, and nystagmus, meaning rapid involuntary movements of the eyes. So these are the uses of gabapentin, which includes: you can use it as an adjunct with other antiepileptics. Pain which is caused by diabetic neuropathy can be reduced with the administration of gabapentin, and you can also use it to reduce the pain of post-herpetic neuralgias. So these are the additional clinical indications of gabapentin, diabetic neuropathy, and post-herpetic neuralgia, apart from epilepsy. Topiramate is well absorbed orally, around 80%. It has no effect on absorption. It has no effect on microsomal enzymes as well. Around 9 to 17% of it is protein bound. It is mostly excreted unchanged in urine. It has a plasma half-life of around 18 to 24 hours. Now let's switch gears and talk about its mechanism of action. So basically it has multiple mechanisms of action. It blocks voltage-dependent sodium channels. It reduces high voltage calcium currents, L-type. It is a carbonic anhydrase inhibitor. It may act at glutamate NMDA receptors and may block them, and in this way it actually decreases the excitatory influences of glutamate across the postsynaptic neurons. Topiramate has specific side effects as well, psychological or cognitive dysfunctions, meaning you could have a memory loss if you're using it. It causes weight loss as well, and urolithiasis, kidney stones as well. Gabapentin is restricted because of the pharmacological effects. However, it is a drug of choice for infantile spasms. It is not bound to proteins, not metabolized and excreted unchanged in urine. Its plasma half-life is around 4 to 7 hours. Mechanism of action includes it inhibits GABA metabolizing enzyme and increases GABA contents in the brain, which is highly similar to valproic acid. Side effects include visual field effects, psychosis, and depression. Limits its use. This slide is projecting the management protocol of status epilepticus patient. Maintenance of airway breathing and circulation initially is very important in managing patient with status epilepticus. After that, administer your patient lorazepam or diazepam. If the seizure continues, or if your patient is unresponsive with the therapy, give him phenytoin or phenytoin. Even if the seizure continues with the repetitive administration of phenytoin or phenytoin, give your patient phenobarbital. After you see that repetitive therapies administration of phenobarbital is not working, then you can administer your patient IV anesthetics. That is propofol or midazolam. Hence, it is important to know that maintenance of ABC is very important. After that, lorazepam, diazepam. If a patient is unresponsive with the therapy, give him or her phenytoin, phenytoin. Even if the seizure continues, then give him phenobarbital. Even if the seizure continues and your patient is unresponsive with the therapy, give him IV anesthetics, propofol or midazolam. All right. Good going. So this is the MCQ. I want you people to answer. Which one of the following antiepileptic drugs does not act by sodium channel modulations? Phenytoin, carbamazepine, lamotrigine, or phenobarbital? What do you say? What do you say? Phenytoin? No. Carbamazepine? No. Lamotrigine? No. Phenobarbital? Think about it. So answer is D. I hope you have enjoyed the video and subscribe to my channel on YouTube, and you would have more videos in the near future. Thank you so much for watching the video. Stay home, stay safe, work hard, take care. Bye bye.